Well, welcome. I'm Meg Barron. I'm AMA's Vice President of Digital Health Strategy. Thank you for joining us today. Today, we're going to be discussing our latest digital health research that's focused on how do we close the digital health disconnect. And we've developed a blueprint for how do we optimize digitally enabled care in today's environment. We've developed this with numerous collaborators, including our research partner, Manatt Health. And we released this at HLTH Health Conference in November of this past year. First, just a disclaimer for today's presentation. I'll read that for just a moment. So our agenda for today will include some brief background on this research. And next, we're actually going to do a viewing of our presentation and panel presentation that we held at Health in November, followed by a live Q&A with myself and our research partner, Jared Augenstein from Manatt Health. And first, I just wanted to provide a little bit of background for those not as familiar with our AMA Immersion program. This is a series of webinars, virtual panel discussions, peer-to-peer learning sessions, and boot camps, all that focus on best practices and really lessons learned from across practice settings and different geographic settings. The focus of this programming and really overall education is on not only adopting new technologies, but even more so, how do we optimize both in-person care and virtual care, and an emphasis on both the realities of practice today, but really with an eye towards what opportunities are coming and coming quickly that practices and systems can explore. At the highest level, our AMA digital health strategy and overall research strategy and initiatives are focused on how do we help to ensure technology can really help be an asset and not a burden or one more thing on the plates of physicians and care team members and patients across the country. This has included historical baseline digital health research that the AMA and our team has led, as well as playbooks that are really focused on being as pragmatic as possible in terms of best practices and step-by-step checklists and resources for how do you go about not only adopting new technologies, such as remote patient monitoring and telehealth, but really also helping to showcase where successes are being seen and where lessons learned have also been experienced across the industry. One other thing I'd call out is some research that we also did with Manatt Health, which was to develop a virtual care value framework for how do we assess the value of virtual care beyond just short-term ROI or financial ROI, but bigger picture for things like health equity, for improved patient access, for improved clinical outcomes, and also improved patient and physician satisfaction scores. And from all of this research, we know that physicians and patients want remote care and access to continue, but that despite over $100 billion of investment in the last 10 years, we're still only really brushing the surface of how to optimize in-person and virtual care for improved outcomes. So we're truly at an inflection point to how do we navigate both existing and emerging models of care. And this is also inclusive of how do we best blend these emerging kind of what historically has been direct consumer technologies and solutions with traditional brick and mortar settings, and where can collaborations and partnerships really come to fruition. So collaboration is absolutely going to be necessary, and that's really the ethos of this latest research and blueprint for digitally enabled care that we've developed. So I always love a visual, and I recently was at the Consumer Electronics Show that had a large digital health track this year, and we had one of our physician board members actually present at the keynote, and I think he said it very well during that keynote presentation that the current state right now is really analogous to almost Fred Flintstone and George Jetson coexisting and attempting to share from both of their different perspectives, and that we've made such tremendous strides with technology development and really adoption, yet we still find ourselves in these situations of needing to fax the results of a procedure to someone or having 4,000 clicks a day in an EMR. And again, back to this inflection point that we find ourselves at of how do we best optimize both the virtual experience and traditional brick and mortar in-person settings where those are absolutely necessary so that we've got as improved outcomes and experiences as possible. So our process and approach for this research has included interviews and workshops with stakeholders all across the industry. And this has included physicians, patients, VCs, venture capitalists, vendors, health system executives, payers, specialty societies, and employers. And really what we wanted to do is first level set on the current opportunities, but also friction points and disconnects that are being experienced really across the ecosystem. And all with an eye towards how can we collaboratively address these, because none of this can happen in a vacuum and no one group can address this on its own. So the overarching consensus that we found from all of these different interviews and workshops that we've held is really we need to continue focusing on fixing the foundational issues. So think interoperability, think care fragmentation, that we're at risk of only additionally exacerbating if we don't find a way to better connect the dots in this space. And then also to ensure that patient and physician and really caregiver involvement in these new emerging care models is really at the center of the discussions. And from all this feedback and level setting, and again, we've had over 40 plus contributors to date from all of those different stakeholders groups, we began to actually outline what we hope to be a very pragmatic blueprint for how we work together and how we can better work together to achieve digitally enabled care. And this is inclusive of foundational pillars that the industry as a whole can really both attest to, but also use as a guiding light for how we go about next steps in this space. And then also some calls to action for each stakeholder group to think through in terms of how they are and how they can be contributing to next steps in this space. So before I stop here to turn to our presentation and panel presentation from health, just a brief call to action that we'll speak more about at the end of the presentation today. But we are looking for collaborators to get involved with us on the next steps for this initiative. So if you are a physician, a health system, a vendor, a payer, employer, we want you to join us in the next steps for this effort. And again, we need everyone to come to the fold if we're going to help move the needle and both fix some of the foundational issues that we know exist, but then think through how can we best optimize digital experiences and blend that with in-person traditional care. So thank you, and we look forward to sharing the panel presentation and then look forward to some live Q&A at the end of the presentation today.
All right. Welcome, everyone. Thanks for coming. My name is Jared Augenstein. I'm a director with Manat Health, which is an integrated consulting and legal practice. And we've been working really closely with the AMA over the past few years on this work, and really excited to be with you all here today. We're about 2 decades in to the digital health world, and we've been taking stock over the last 6 months through this work of what's really worked well, what are the challenges, and how do we overcome some of the barriers that still exist in terms of delivering on the full promise of digitally enabled care. And that's what we're here to talk about today. Thrilled to have these wonderful panelists with me here. I'm going to ask each of them to introduce themselves. I'm going to start with Meg, who's also going to share a little bit more about this work, which we'll get into during the panel. Meg?
Sure. Well, great to see everyone. I'm Meg Barron. I'm Vice President of Digital Health Strategy for the American Medical Association. At the highest level, our team is really focused on how do we help to make technology an asset and not one more thing or one additional burden or one more click for physicians, patients, and really the entire care team. And we know from various research that we've done, we do pretty regular digital health benchmark research to really get a pulse for what physicians are using today in practice, what they're excited about, and then what their key requirements for adoption are. And then also we've had the pleasure of working with Manat Health in the past on developing what we've termed a return on health value framework for how to measure the value of virtual care and really valuing that beyond just short-term ROI, but really thinking more holistically around how is virtual care helping us to measure improvements for patient access, improvements for, of course, clinical outcomes, but also things like patient and physician satisfaction that, have been harder to really aggregate and to be able to see if you're not really deliberate about seeing a snapshot view for that. So despite knowing that we've seen a growth in interest, obviously a growth in adoption for digital health during the pandemic, and really an interest from both patients and physicians for that to continue, and that we know outcomes are being created from things like this return on health value framework and what we're hearing nonstop at these events and conferences at all, there's still a massive disconnect, right? That we're not able to see at an aggregate level really the outcomes and results that we need to be seeing, especially 10 years into digital health or more, right, at this point in time. And that's really why we set out to work with Manatt again on further exploring this and recognizing that no one group can do this alone. So we have to collaborate, and now more than ever, with physician burnout at an all-time high and really a tsunami of need for chronic care and behavioral health and an aging population, technology will have to be an essential player if we're going to improve outcomes. So this is where, we're really focused and looking forward to working not only with those on the stage today and those that have been contributors for this research, but many of you in the audience and others at this conference to help bring this to life. So great to be here, and thanks.
Good morning, everyone. Really excited to be on the panel today. My name is Samir. I'm a practicing gastroenterologist and chief medical officer at Oshi Health, which is a virtual first company treating patients with digestive health conditions.
Hi, everyone. Alyssa Jaffe. I'm a partner at Seven Wire Ventures. We are a venture capital firm focused on investing in digital health companies under the thesis we call the informed, connected health consumer. So everything that we do is about empowering people to become better stewards of their own health and really thinking about healthcare technologies and services meeting people where they are. We're an operator-driven model. We invest in companies. We start companies as well. And our LP base is about 60% strategic. So amazing organizations, provider organizations, health plans, self-insured employers, pharma who work with us and our companies to drive growth. Thanks for having us today.
Hi, everybody. Andrew Diamond, honored to be up here and to be with all of you. I am myself a practicing internist and chief medical officer at One Medical, which is a now nationwide primary care practice, started as a solo primary care practice in San Francisco and has grown to more than 200 offices across the country now. It's a membership-based, technology-powered model that really aims to address all of the major components of the quadruple aim, deliver better outcomes at lower cost, more delightful experiences for the patients and for the clinicians and the entire care team, and ideally do that in an economically sustainable way. And we've been part of what we considered, the digital health transformation since the inception 15 years ago, doing both virtual and in-person care.
Great. So I want to lean back into that. So One Medical has been at it for 15 years. I'm going to kind of go down the line here, but I'm curious your perspective on, as you reflect on the last 15 years, what's really gone well as you think about delivering on the promise of virtually enabled care, and where do we still have kind of room for improvement? And you can share from One Medical perspective, and then I'm curious for all of your takes on this question.
Well, it's a great lead-off question. I think the obvious answer to what's gone well is that we started doing virtual visits as part of our care model, initially just kind of going asynchronously through the app, and then adding video when that became technologically possible 7-8 years ago, something like that. But especially in the last few years, the embrace of remote care by patients and by clinicians has gone, I think, very, very well. And the fact that it is now just widely understood that that is a good way to get care for the kinds of situations that are amenable to it, and that it's worth adding that to your practice model. I think that's gone really, really well. I'm less enthusiastic about the state of just communication between clinicians across different systems. And I think we've made great strides in terms of interoperability and standards for interoperability, but I still feel as though a lot of the information that I receive from external sources as a clinician is a lot of irrelevant stuff. And I think we have a ways to go before we've kind of restored the spirit of really quick, efficient, pithy communications between physicians and other care team members to really understand what's going on with the patient. I think where One Medical is putting a lot of energy is into these really curated relationships with leading health systems around the country to enhance the quality of that communication. You know, we can communicate really well with our patients virtually, but communicating with other clinicians effectively so that all the data can flow, but really the core of what really needs to be understood about a patient can also flow in a way that doesn't mean you have to sift through a 60-page continuity of care document.
It's really interesting, Jared. You asked a great question. The last 15 years in digital health have been kind of wild. Like, you think about, we went from ACA and this notion of like, what does value-based care look like, which I'm sure we'll talk a little bit about today. Fast forward, and there's nothing that what happened like the pandemic. And while catastrophic, it became such an accelerant for many of us in this room to think about our own healthcare and think about our own experiences and what that means to be a steward of health. And so what have we done right is we've actually kind of tried to figure out, hey, there's this thing that everybody utilizes and everybody has access to, but all of a sudden, when we can't go to the one place we need to get it, how are we going to get it? Because it's not a nice to have, it's a need to have. And so the innovation that we've seen across the board from so many organizations, both public, private, big, small, I work with a lot of early stage innovative companies who partner with giant incumbents to think about, what does care delivery look like in the next generation? What does that mean for large organizations, and what does that mean for consumers? And I've been really proud to see the ideation and the innovative thinking of how to really deploy that. Now, you ask, what could we do? What have we maybe not done or not done well enough? And I think Andrew said it well of he's talking about data and he's talking more about infrastructure, but that also relates to, meaningful data for a consumer. And how do we get access to our own information, connect into the system connect back to us to improve our own health outcomes. And that doesn't diminish the role of the provider, it enhances the role of the provider. Because at the end of the day, we are not sitting in our provider's office 24 hours a day, 7 days a week. And when we leave and we go home, or we end that Zoom or end that phone call or end that text message now, we have to know what to do. And you think about some of the major chronic conditions in this country, or even things that were acute like oncology that are now moving more into a chronic condition. You have 5 new providers who are trying to navigate your cancer diagnosis and you don't know what to do. And so we have to be in better service. We have a major, Meg mentioned this, provider supply shortage in this country. So we have to create the extension of providers so consumers are empowered to be better stewards of their health.
Yeah, I couldn't agree more. I mean, the pandemic showed us, so beyond the last 15 years, recently, the pandemic showed us something we all always knew. Patients want care in a more asynchronous way. They want care in a more convenient way. But unfortunately, I think one of the areas we can do much better in is not designing workflows that are just built on traditional ways of delivering care. And so we all know that the traditional way of delivering care has an appropriate need. Virtual care is not going to be a panacea to fix all these problems that, Alyssa and Andrew just mentioned. But one of the areas that we can really kind of seize this opportunity that we have as virtual care companies to purpose build things from the ground up, thinking about new workflows, new care delivery models, meeting patients where they are. A lot of the complex care that we deliver at OSHI, for example, GI is a very complicated field. You can't do things, you can't go to an in-person visit every week, right? You can't go to an in-person visit multiple times a week. So how do you build a model that meets that patient where they are and gets them the type of care they need in a very convenient format?
Yeah, and I would just layer in, when we speak about, a move or a desire as a North Star to move towards digitally enabled care, what we mean by that is not to introduce just yet another buzzword of sorts, right, in healthcare, but it's really how do we move beyond just this world right now where, yes, you have access to virtual care, yes, you have access to traditional brick and mortar, but the end goal is how do you make that as integrated and coordinated as possible, right? And we want the patient convenience of that. And we also want, of course, to be able to have access when you need to see your existing primary care physician, or to have that data be actionable and have the piping, right? To use our blueprint analogy of, you need to be able to have the piping work and all, and not just have digital kind of window dressing of sorts that, you know, isn't really going to get us where we need to be. And I truly feel, and I'm passionate about, that this is such an inflection point for the industry. And there's a door that's been opened by the pandemic to allow us to really help to have digital care, if we're thoughtful about it and really approach this from an equitable perspective, to really help us redesign or really remodel the current care experience. So this is where I think partnerships and collaborations are going to be critical. The one last thing I'd say back to burnout is, I mean, again, the stats that we've seen is that we're going from 38% of physicians that said that they were very burned out in 2020 to 63% of physicians saying that they're extremely burned out, and 1 in 5 physicians saying that they're going to plan to leave practice in the next 2 years if things don't improve, right? So you've got this massive opportunity for collaboration, right? And we want to make sure that physicians and practices and health systems feel empowered to partner and to figure out how to make these collaborations work as effectively as possible.
So one of the things that I've kind of observed over the past 10 years that's been interesting is there's many ways of slicing and dicing all of the thousands of companies that have been started over the past 15 years, all of whom are in the exhibit hall next door. One of the kind of ways of slicing it is many. One of the ways of slicing it is, organizations that are building kind of care delivery models from the ground up. They're delivering the care directly, and they're in some cases seeking to partner with, but in many cases seeking to kind of disintermediate the traditional, primary care and overall healthcare system. Then I would say there's organizations that are trying to kind of, empower traditional providers and clinicians, and there's a gray area too, of course. So I'm curious for your take on, which of those paths seems most likely to be successful. And Alyssa, I'll start with you just from a investor perspective. As you're evaluating companies to invest in, how do you think about that kind of distinction? How do you think about that in the context of your investment making?
Yeah, we think about it a lot, and we actually have a pretty strong stance on this. And I do want to caveat. So for us, our answer is the former. Our answer that we invest in businesses that focus on consumer-directed care. Again, that doesn't mean there's not providers as a part of that, but it's focused on empowering people to be better stewards of their health. And there's a number of great businesses in this world that focus on helping providers, that focus on infrastructure, that focus on making providers more efficient and effective, and health plans more efficient and effective, pharma, whatever it may be. And there's a very strong place for that. But the true north, the world we're trying to build, is the world in which consumers understand their information and are better stewards of their health. And frankly, this is healthcare. Like, we are in the business of delivering care. And while there's so many ancillaries around that, the crux of what we feel is the value and the way you can actually inflect change is if you are at the forefront. And it's hard and it's messy, and frankly, it's very hard for a lot of generalist investors because, welcome to healthcare, where it takes 18 months to sell a contract, and it's very challenging sometimes. And going through the provider credentialing process and thinking about how you're going to recruit and train and retain those providers, and what kind of care is being delivered, and the highest quality care that's delivering the best clinical outcomes. And then when you go to work with an incumbent organization and you go work with a health plan or provider, that they say, yes, this is a solution, albeit virtual or not, we want to work with, because this is the best clinical experience and drives the highest level of clinical outcomes for our patient population. And so companies that focus on that are the companies that we want to work with.
Andrew, One Medical's kind of evolved from, having direct primary care to now you have many health system relationships in the markets that you're working in. And I wonder, what led to that decision about the kind of feeling the need to have these health system partnerships, and how has that changed, how you think about delivering care in a holistic way.
Well, the real driving force behind it was sort of a natural result of our focus on primary care. And I think that we could spend a whole other panel discussion on the criticality of primary care. When I think about the provider shortage and the state of burnout among providers, I worry especially about primary care. I think there's universal almost understanding that if we really want to fix the greatest ills within healthcare in America, we're going to have to continue to invest in primary care. And so One Medical has tried to stay very focused in primary care. And we've been able to generate great results and really delight our members and really delight our clinicians and attract more clinicians. But we would consistently get feedback that where our members were dissatisfied was in access to specialty care and in the experience that they had when they went to either try to book an appointment, or how long it took to get the appointment, or what the appointment was like, and what data was available to the specialist, and vice versa. So really that's at the heart of creating these relationships with our health system partners across the country. It's the opportunity to create better access to specialty care for the One Medical members, and more seamless exchange of data, as I was alluding to earlier. And I think that, one hoped for, I got to find some wood, but hope for eventual benefit, something that we're starting to work on more deliberately now, is helping in many cases, our health system partners are academic medical centers. They're doing their own training of clinicians, getting those clinicians to be able to rotate through One Medical clinics, either as students or as residents or otherwise, and have that experience and see that actually there is an environment in which you can practice primary care that's delightful, when you're really practicing the kind of care that you always dreamed of. So we're hoping that helps alleviate that provider shortage in the long run, just giving more people insight into what it can be like if you've got a well-designed system.
Can I also say, I commend Andrew and the One Medical team. It is unbelievable to sit up here and to say, hey, we did all these things great. This is what we were purpose built for. But then we kept hearing this other thing from our members. And they said this was something that they were dissatisfied with and frustrated with. And so we found a way to solve that problem. And companies that do that, you ask me, what do I care about? I mean, that's real insight, because at the end of the day, we constantly are evolving in service to everybody in this room, to the patients that we have, to the consumers out there, and that's so nice job.
Thank you.
Samir, I'm curious for your take on this. I mean, OSHI almost by definition has to work, within the context of the primary care system, because you're delivering subspecialty care. And so how do you think about doing that in a way that really works for your members and that works for your provider partners?
Yeah, it's a great question. I think, one of the things you have to be very mindful about when you're building a virtual care company, especially in subspecialty care, is thinking about the fact that care is delivered in very different ways across the United States, right? So the compelling issues that face a primary care physician in the Metro New York area, very different than Jackson, Mississippi. And so OSHI works both with primary cares, but we also work with our GI brick and mortar colleagues, right? And so you have to be very mindful about not taking a one size fits all approach, right? In an area where there's a lot of competition, there's a lot of gastroenterologists, the things that are important to think about when you're managing a GI patient, very different in rural Louisiana, where the closest GI doctor might be 200 miles away, right? And you mentioned care disintermediation as well, right? And I hear this a lot. I talk to a lot of doctors, and some of them just kind of have their head in the sand and they just think virtual care is this interesting trend. Others really are worried about it. They do think that it's a competitive nature. They wonder what impact it's going to have on their autonomy. They wonder what impact it's going to have on their, the connection they have to their patients. But I think after you think about what's going on in healthcare, digital health is not the disintermediator between a brick and mortar physician and their patient. The disintermediation of care is really occurring by rising operating costs, downward pressure on reimbursement, increasing prior authorization, patients demanding more and more services from the type of care that they want. That's care disintermediation. It's making it very, very difficult for any sort of brick and mortar provider to keep up with these types of things. And so I think the opportunity for virtual health is to fill in the gaps and actually give that clinician back the time they need to do the type of care that they're perfectly designed to do, right? If you have gallstones in your bile duct, Oshi's not going to be able to solve that problem if you need to get an emergent ERCP to get that treatment fixed, right? Likewise, chronic longitudinal care of complex GI conditions, brick and mortar GI practices are just not well designed to treat those types of patients, right? We've known for years and years what we need to get patients healthier in many conditions. The problem is we don't have the resources or the reimbursement structure set up to actually execute on what we know. So it's not medical science or a new drug that's going to solve those problems. It's really just different care models and thinking about touch points with patients in totally different ways, which virtual care is perfectly designed to do.
I want to stick with you, Samir. One of the data that are emerging on kind of, telehealth utilization at this point in time. So there's this big spike during the COVID pandemic. It's kind of leveled out a little bit. I think the latest data I've seen are about half of behavioral health visits are being delivered virtually now. Maybe about 10 to 15% of primary care visits are being delivered virtually now. But if you look at specialty care, it's really low. I mean, it varies by specialty, but they're all under 5%. Some are 1%, some are 2%. Why is that? Why is 95% of specialty care kind of back to being delivered in person? And how do we kind of, get out of this now trough that we're in and get to whatever the right number may be, which is going to be clinically, specific and patient specific and situational specific.
Right. I mean, from my perspective, I think it depends on what you define as care, right? Traditionally, what we've thought of as care is an outpatient, face-to-face visit with a provider, right? And that can be done either in person in the office or over telehealth. But if you think about care to broaden the aperture of what we think about as care, it really should include things like messaging with your health coach, messaging with your physician, right? I'll tell you, that has not gone down. So when I look at my EMR inbox, the number of patient messages that I get every day is going up and up and up. That to me is virtual care, right? The patient has a question, they have a need, and they don't want to come in. So while traditional office visits have kind of gone back in many cases, in many specialties to pre-pandemic levels, the level of asynchronous care that physicians, brick and mortar physicians are delivering is just continuing to increase. So, I think it's dependent on what you really label as care. At some of these virtual first companies, Oshi included, we do face-to-face, not face-to-face, but kind of virtual office visits, the type of care that you would kind of traditionally think of. But a lot of the care is delivered behind the scenes. A lot of the care is the asynchronous messaging, the time spent reviewing records, the time that you spend with a dietitian or a psychologist or an ancillary provider. So it really depends on what you're thinking about as care.
So I hear that. And I hear two things. One, that sounds really good for patients because they can get access to their provider when they want and the way they want. On the other hand, I hear your inbox is filling up and you're getting more messages than you ever used to. And that makes me really feel for the clinicians who are on the receiving end of that. So Meg, I want to kind of get your take on this because AMA's done some research on this. And then Andrew, I'd love to get your take, from the primary care perspective.
Yeah, I think it's a delicate dance, right? And what is the right mix of the right care, right time, right modality of care? And I think that's so use case specific, right? And specialty specific at times. But it's also, I think, again, we're just brushing the surface of how do we better bridge together the right technology solutions for that right use case, right? And we had the opportunity, we have a whole digital health implementation playbook series. So we have a playbook for telehealth, a playbook for remote patient monitoring. The next one that we're doing is on health at home. And that, is a relatively new-ish, right? Depending on how you define it, kind of exploration for a lot of health systems and practices that recognize the need for that. But I think what's missing, and one of the chief strategy officers from a large health system that we were interviewing as part of this, when we asked him just kind of friction that he was having or experiencing when trying to figure out what's the right bundle of solutions to have, he's like, in what other industry, if I had a grocery list, would I have to go to, of 10 different things on my grocery list, 10 different stores, right, or 10 different sites to be able to get what I need on the list. So if I needed to go to a store to get my fruit, a store to get my frozen food, a store to get whatever, right, and none of these things were coordinated, that's not a good user experience, right? Like on any front whatsoever. And then same as from a patient, being a patient myself, right? You want the convenience of being able to have access to virtual care when you need something right away, of course. But then I think what oftentimes is happening is the fragmentation behind the scenes of how and if that information is getting back to your primary care physician and how that can be better coordinated across the board.
All great points. I think, our take in the primary care world is at One Medical, we've talked a lot about trying to own the complexity of care. We sort of invite patients to tell us, well, give us all 10 items on your grocery list and we'll take care of it and we'll deliver it by drone or otherwise to your door. Which is a lot to ask of primary care. I think where patients really get hung up is we're creating a world in which the patient is increasingly expected to know, well, for this issue, I should open this app and send a message. For this issue, I should open this other app and book an appointment. For this issue, I think I need to see a specialist, some sort of ologist. I think it's a neurologist, right? I think that's a lot to lay on the patient. And I appreciate what you were saying about, Alyssa, about the need for solutions that help patients take better care of themselves. But of course, there are a lot of situations that arise where patients just genuinely don't have the expertise to know. What we try to do at One Medical is, when we get that, the healthcare equivalent of a 10-item grocery list, that may hit the PCP inbox, right? We're basically trying to create a world in which patients know, like, just go to primary care, just go to One Medical, like they'll figure it out. And that list that message may hit a provider's inbox, but we also have our virtual care team available 24/7 that can be scanning some of those inputs. We have machine learning that's pulling some of those messages out and reassigning them to other teams that are better able to handle some of those issues. So this is where the importance of tech-enabled team-based care is really obvious. We can create better user experiences so that the patient can just tell us either what are these 10 items, or maybe it's just one particular question. And we could say, well, for that, you need to talk to this person, or for that, you need this appointment with this person, and here's 6 options for you. So, there's obviously a lot of work that needs to be done here, but I think that having both control over the technology and what that patient user experience is, as well as where all of the requests get routed, and being able to sort of staff all of those teams appropriately and have people able to move between in-office care and virtual care depending on their own living situation as clinicians, or I shouldn't say their personal situation. Like, having all of that flexibility is really going to be crucial to ultimately reducing or making the inbox manageable.
And how have you, we were talking backstage a little bit about kind of the technology stack at One Medical, and we were talking a little bit about the technology stack at Oshi, and maybe I'm going to get in trouble here for revealing secrets, but so you've built your own EHR, you're in the process of building your own EHR. There's a lot of EHRs out there, but you've both talked today about kind of the need to have the technology really support kind of the care models that you're building. And I wonder if you could talk about how you came to that decision and what that's been like. I mean, One Medical is kind of a few years, I think, past where Oshi is in this development, but that's a big lift, and why, but you must have felt it was kind of necessary to enable the care model you wanted to deliver.
Yeah, I mean, it was a founding thesis from the very inception of One Medical. The founder knew we were going to have to build our own tech to support the care model that we were going to define, and that trying to cram the square peg into the round hole was not going to work. The other incumbent EHRs just had too much either tech, what would become tech debt over the next 20 years, or just systems designed to run hospitals or basically run systems that had grown up in the old way of doing things. To do them our way to really rethink the way healthcare is delivered. Primary care certainly is delivered. We were going to need that control. So it has been a long journey. It's been interesting to see. I have my own personal running list of things I would like to see in our EHR, and it's a very long list, and I share it with our tech team all the time. And the good news is it also includes all the things that we have built. And so sometimes I'm like, oh my gosh, there's like this list of 8-page list of things that I still think we need to do, but then there's 20, 30 pages of stuff that we have actually gotten done over the years. So that's very gratifying. But I still think it was the right decision. It remains really important to have that level of control over the tech.
And it's interesting to hear how much, I feel that, the sense is that a lot of the off-the-shelf kind of EHR systems that are being purchased, you don't get to have that level of, oh, I really want this specific feature, and you have a team that can build it and kind of deliver that to support the care model. So you have a lot more flexibility, it sounds like.
Exactly.
Yeah.
Well, I would say for our companies, and sorry, of course I have like a tickle in my throat here. Lucky me, great timing. But a lot of our companies, what we see is not just for the customization, which I think is really helpful, particularly for providers, but also as you think about the scalability and what that means to translate the solution that they've built across and servicing tens or hundreds of thousands of people and potentially millions of people. And technology has changed so drastically since the original EHRs were built, and two of my colleagues were CEO and president of Allscripts and very keenly aware of what that entailed. But where it is today now is the agility to make strategic decisions and to shift with the changing times in healthcare. And this is why early stage companies and innovative companies were able to move so quickly in the pandemic, because many of them also had the underlying infrastructure that allowed them to quickly pivot and be in the business of care delivery.
One of the things when you're building a virtual care company, you have the opportunity to really be mindful about things that traditional care has neglected, right? Things like incentives, provider and patient experience, culture. And those things are really buzzwords today in traditional healthcare, but they have a dramatic impact on some of the problems facing all of us, right? And so things, the EMR documentation example, one of the reasons why we've such a big interoperability problem and a lack of meaningful data problem is because of the perverse incentives we have in healthcare that we place on clinicians when they're documenting in a traditional EMR. And so that was really what was the impetus for us at Oshi to think about this from the ground up and think about, okay, how can we design not only an EMR, but a clinical model where our providers have protected time at the end of a visit to document, right? When we're in commercial calls, I try my best to make really sure that our payments are not tied to something that's going to require some obfuscated, meaningless documentation, right? But the EMR example, I'm a researcher. Before I was at Oshi, a lot of my time, my non-clinical time was spent researching. And when you're looking at large data sets, aggregated data sets, and you don't know whether that data is true or not true, or what the incentive was for the individual provider at that time to document that individual data point, makes it really difficult to understand what's going on at a population level. And so that's really the reason that we set out to kind of build the system that we're building now, so we can be very, very careful about when we're collecting data and we're looking at data and running predictive analytics and getting to know our population. We know what that data means because we helped design it, right? If somebody doesn't answer a question in the EMR, does that mean it's not there? Does that mean the patient doesn't have that symptom, or they just didn't feel like answering that question? And so you have to be very mindful about provider psychology, the incentives, the time that they have. But like Andrew said, we feel in the long run that it's going to really be a competitive advantage and help us take better care of our patients.
The one thing I'd add to that is, we know that physicians are spending 2-to-1 time right now on administrative burdens versus FaceTime, be that virtual or in person, right, with their patients, and why they got into medicine in the first place, which is just not okay, right? So that has to be improved. But at the same time, when I think about the EHR and kind of the potential of the outcomes data that is there, if you can make it actionable, is really, again, the North Star that we need to get to in digital health. And, the question that we get asked all the time is, just tell me what works of these, like 300,000 apps and solutions that are out there. Can you just tell me what works? So we attempt to do that through case studies and best practices and resources that we put out. But still, I mean, this should be an easier way, right? And that's a huge reason that we're kind of embarking on this blueprint for digitally enabled care, is we need a better way to be able to showcase, right, and really have a showcase of what is working and what's not. And let's talk about what's not, right? And really try to break that down as best as possible. I also think the concept of kind of formularies that are beginning to, additionally emerge that are directly integrated into the EHR, so you can start to see outcomes data, is interesting, right? To be able to see if an app or solution was actually prescribed or starts to get utilized by a patient, is that equating to better outcomes or not? That is something that I think we need to move towards in order to really move the needle or move the industry ahead.
I want to build on that, Meg. So, I'm going to get dark for a second, but if you look at
it's so dark all the time.
You look at, I'm an optimist, but just for a second, we'll bring it back. If you look at kind of where we are at the healthcare system today, costs go up by usually more than inflation every year. Life expectancy has gone down for the past 2 years, and it's really hard to find examples of where quality of care is being meaningfully improved. It's kind of, it's depressing. And so how do we avoid creating, and there are myriad kind of reasons for that, right? There's the opioid epidemic, there's the COVID pandemic, there's, medical cost inflation, there's the aging of the population, there's many reasons for it, but there are these kind of fundamental, issues with the healthcare system today. Care remains highly fragmented, data remain highly siloed, payment models are overly complex. All of this has kind of come up in today's conversation. Clinicians are overburdened. So as we think about kind of designing what the future, of healthcare should look like, it's going to be more virtual, it's going to be digitally enabled, but how do we avoid creating some of those same challenges that plague our system today? It's an easy question. Who wants to start? Meg. Okay, Andrew.
Well, I have an easy answer, which is I think we've got to invest in primary care. I mean, I think primary care, almost by definition, is the assembler, like the aggregator, the home for all of that otherwise fragmented data. If you've underinvested in primary care, if you're burning out all the primary care physicians, if nobody wants to go into it, if they're at the bottom of the pecking order when it comes to new technology, then everything's going to stay fragmented, because we've sort of, we at least in concept, we continue to rely on primary care as the home for all of that information. So, and as the unifier, maybe that's the word I'm looking for all of it. And, anybody who's in primary care is proud of that. We want to be thought of as that home, as that medical home, to use a somewhat dated term, but as, the folks who collectively with the patient see the big picture, see the overall view, have a holistic approach. That means, we got to stop giving it short shrift and really genuinely invest in primary care. And I think, we're starting to see that happen. But to me, that's the solution.
It's super interesting, in particular because, think about primary care really drives 70% of all care and what that means on the downstream. To me, though, I'd maybe pivot a little bit of my answer to you. How do we not repeat it? Is we got to get care out of the four walls of a hospital. That doesn't mean the hospital doesn't exist. But what a hospital is intended to do and the care that's delivered there is top of the licensed care. It's high acuity care. And everything else is meeting people where they are. That healthcare should be ubiquitous, the same way banking is, the same way I can, go on the app and mobile bank, that I can call my bank, and then I can walk into a bank if I need to. And so how do we get care into the home? How do we use care extenders? How do we think about not just servicing in a one-to-one care, but thinking about communities and families and going to places where those people are? And, ultimately, particularly you talk about rural populations and the servicing there of every community has a group of collaborative thinkers and community-driven mindset, but we aren't delivering care that way, and that's a real miss in healthcare.
Yeah, to follow up on that, I mean, the reason it's so hard is because people's lives are at stake. right? This isn't digital banking. It's not entertainment. It's not Uber. It's not, building electric cars, right? We're all sitting here in Las Vegas, beautiful conference, beautiful convention center. But if you think about it, we're treating patients when they're their most vulnerable, and people's lives are at stake. People's, symptoms are affecting their ability to work, care for their children. And so it's really, really tough. I think what came to mind for me when you asked the question, Jared, was pushing back on the traditional line of thought in healthcare. So whether you're on the commercial side and you're negotiating with an actuary at a health plan, or you're negotiating with a health plan on how you're going to get payment, sometimes it's a lot easier to just, say, okay, fine, let's just use the CPT code and be done with it, right? Or if you're building an EMR, or you're thinking about how to train your clinical team, it's a lot easier to just continue to do things the way they've been done. But we have to fight back and push against that and really spend the extra time educating the market, educating the stakeholders, pushing back on the way things have been done traditionally, and just move one step at a time. But it's going to be slow, and it should be slow and steady, right? The bar should be much higher with regards to operating excellence and standards. And that's expensive and difficult, especially for startups to do. But like I said, just because of the nature of the type of work we do, that should be the standard, and it should be set very high.
I'd say the last, major piece that we're looking to really move forward as part of this research and future of health effort in general is everyone has a part to play in this, right? And again, no one group or no one entity is going to do this alone. So when we think about everyone that we even interviewed as part of this report that we just launched yesterday, which is payers, health systems, large employers, the vendors themselves, physicians that are working in traditional brick and mortar settings, physicians that have gone to work for some of these new digitally enabled companies, right? There's pieces that are working well-ish, there's pieces that aren't. And I think that we have to collaboratively poke the bear on what's not working and do that in a way to say, hey, we're open to partnerships and we have to partner if we're going to do this right? Now more than ever, we absolutely have to. And I think those are the groups and those are the companies that are going to have the most success, and those health systems that are open or receptive, and those practices that are open or receptive to, again, knowing where that right balance is to strike of where you can collaborate and partner and recognize you don't have to build everything in-house is, again, where we can start to see some successes. And what we're committed to from an AMA perspective is how do we help to be that kind of pre-competitive convener of sorts for that, and how can we help to showcase and really amplify where we're starting to see some wins.
And there are definitely some wins. I mean, just,
Yes, lift us up, Andrew.
No, I mean, I think I'm listening to you think. I'm listening to you speak and thinking, we've got results where we're saving employers 8%, 40% of their total medical expenses, saving money for CMS, great outcomes. I mean, there are great stories out there.
I think we should finish on a high note, so that's great. Maybe we can, Alyssa, what are you really happy about, from a results perspective over the festival?
I mean, the future is bright, honestly. I'm so excited. My job is addicting. I get to see the future every day, and I get to see what the world of healthcare looks like and make a bet on it. And so, frankly, for us, the macroeconomic environment is really tough, but the way that healthcare is being launched, the way it's being adopted, the way these companies are growing is really, really magical. So we're in a good spot, and I'm pretty excited about what 2023 will bring.
That's great. Samir?
Yeah, I mean, we're really excited as well. I just got news that our prospective clinical trial results at OSHI are going to be accepted for publication and will be out at the end of this year. So, again, like Andrew was saying, the future is bright. We have evidence now, from powerful, methodologically well-controlled, well-designed studies showing that, in a field like GI, right, where a few years ago people would think that's a procedural subspecialty. How do you deliver virtual care for something like GI? But now we have the proof. Our hypotheses have been proven. And I think we're going to start to see more and more, not only investment from, people like on your side of the fence, but also buy-in from providers who are really the naysayers from the very beginning. And we want our providers to not, just jump on the shiniest object. But now we have that proof, and I think the next few years will be really exciting.
I couldn't agree more. And I think, again, interest, adoption has never been higher. And I think the energy off of just bringing the right people to the table, right, is infectious. So, this is a link in the QR codes here to download this report, but we see this as just a starting point. So we're committed, AMA, to building on this into 2023. We need to have more of these discussions. Again, we need to share more of the wins that are being experienced across the ecosystem, and we want to do that together. So please reach out. We're looking forward to further collaborating with those that have been contributors to date, and then getting you on board to do just the same. So thank you.
All right.
Thank you.
Thanks, everyone.
Thank you.
So to kick things off, how can I and my organization get involved in next steps for this initiative? And we actually do have a slide here, the Future of Health call to action. Looking at, are there any examples yet of allowable digital health programs, devices, software for cognitive behavioral health?
So I think it's a complicated space. I think there are, and one that we're looking really closely at now and going forward, and is going to be part of the AMA's kind of future of health research going forward. And it sort of breaks down as to whether the care is being, we're talking about care models in which the care is being delivered by a physician or clinician, or the question also talks about sort of cognitive behavioral health. I think there's another type of behavioral health intervention that's being delivered mostly using software kind of as the intervention for cognitive behavioral therapy, and payment for those types of models is a little bit more limited. We wrote about this and sort of about how important it is to integrate behavioral health into primary care. There's an AMA report on this related to advancing digitally enabled integrated primary and behavioral health care that I would encourage everyone to check out. It's an area that's sort of critically important that we want to continue sort of researching and providing clarity on going forward.
Well, I'll kick it back to you for that first question, but just how folks can get involved with this initiative. And we have here on the slide the call to action as well.
Yeah, that's great. And as everyone hopefully just heard, we're really looking for the collective group to come together here, and more is really more. So in addition to the 40 plus contributors we had join us for the initial report that plan to further have us accelerate next steps, we're really looking for additional groups, be that those from industry and also health systems and practices and individual physicians to get involved. And pragmatically, where we plan to take this next for 2023 is to tangibly really start to build out a few key areas. One is around, and you heard us touch on this in the panel discussion, a case study showcase. So we feel like we need to do an even better job of showcasing best practices, especially around some of the top use cases that are being seen in the industry, of where in-person and virtual care has just a lot of opportunity to further accelerate just the industry as a whole. So that's one thing. And we've mentioned in both the panel and just in past different scenarios, some of our research that we've done for return on health, which is a value framework to be able to see more comprehensively the value that virtual care can really yield above and beyond just short-term ROI. So as we think about patient access, or we think about clinical outcomes, or of course, patient and physician satisfaction scores, we want to use that framework to actually build out a showcase of best practices specific to digitally enabled care. And we'll look to collect those and solicit those from across the industry. The other portion of this that's really important is the payment piece, and really kind of demystifying how are people going about paying for and getting paid for digitally enabled care. And again, when we say that, we mean a combination of really optimizing in-person and virtual care. So to do that, we need that case study showcase of best practices of who's doing what well, but then to further decipher down what existing CPT codes exist for that kind of scenario of sorts around those top use cases. of how do I go about kind of optimizing payment for both virtual and in-person care. So what CPT codes already exist, and then the who's paying for what around that. So what's CMS covering versus what's private payers, and kind of a mix of different private payers paying for. And then where are there really gaps in payment in coding today? And that's where the AMA leads some groups like our Digital Medicine Payment Advisory Group that are laser focused on just that, of really filling in where there are gaps and helping to really aggregate evidence around the need for additional enhancements for payment and coverage for the industry. So we hope you join us. Please reach out to me directly or us, our team, and we look forward to getting you involved.
Another question kind of in the same vein, how can nonprofit organizations collaborate to increase medical cybersecurity knowledge and disseminate best practices to help skeptic physicians embrace innovation while having the necessary knowledge to feel confident in the products they use and recommend for patients?
Yeah, and I can start here, and then Jared, feel free to please jump in. So this, as we know from just our baseline digital health research, when we've surveyed, physicians all across the country in all different practice settings and specialty areas, what consistently comes up as a key requirement for adoption is prove to me that this works and has an evidence base, and then prove to me that I can have a fair payment pathway. So I just talked about that for a moment. But then that third leg of the stool is really the liability coverage piece of this. And that includes cybersecurity, that includes privacy and security, essentials in order to feel confident before you use this or prescribe this in your practice setting. So that's absolutely critical, and I think only going to increasingly become so. AMA, we've got a number of resources related to both cybersecurity. So if you go to our website and search for that, you'll see a whole summary of aggregated resources and tools. And again, anyone that has questions can reach out directly to me and we can help point you in the right direction. We've also released something called Privacy by Design, which is really a guide and framework for developers to be able to use to make sure that they're following the right steps from a privacy and security standpoint. And while the target audience for that is really the developer community or the vendor community itself, I would say that it's a great resource and tool for health systems and practices and individual physicians to be able to use when they're assessing bringing in a new vendor or new company into their environment, because it helps to really have a very good framing for the questions that you should be asking vendors and really the table stake expectations that you should be thinking through anytime that you're bringing on a new partner or vendor or company overall.
Yeah, Meg, totally agree with everything you said. I do think that, and it's great to be reminded of all of the resources that the AMA has available here. That's sort of one of the things that I wanted to reinforce, which is that oftentimes I hear cybersecurity or privacy or security risks sort of generally getting thrown out as a reason to not adopt digital tools. And I think often that's happening in situations where there isn't a really deep understanding of the laws and risks. And so working with your legal or compliance team or yourselves, just getting educated on sort of what are the real risks and what are the kind of rules that you need to follow. And as Meg mentioned, the AMA has some excellent resources available here. That's really important because as we've all seen during COVID, it's certainly possible to deliver, clinically appropriate, safe, private, secure care virtually. And so that obviously it's critically important to be aware of all of the legal and regulatory rules that need to be followed, both at a federal and state level. But it's certainly possible, obviously, to follow them and deliver outstanding care. And so having a really good understanding of what those rules are, but not letting them be an inhibitor to adopting digital tools is important.
I love this next question. What bridges are being created for this optimization in conjunction with the disparity of healthcare populations? And I'll turn this to either of you, whoever wants to go first.
Sure, I'm happy to take a first pass at that. So I think when I think about delivering digital-enabled care to populations that face some sort of disparity or vulnerable populations, I sort of think about addressing those issues in sort of three domains. The first is, does the population think that digital enabled care or telehealth is a good option for them? Is there kind of awareness of the virtual care option? Is there trust that virtual care can be as good as the in-person care equivalent, depending on what the service is? And I think there's a lot of trust building that needs to happen on behalf of the provider community, and in some cases, just as part of a public awareness around the availability of virtual care and the fact that it's safe and effective in most clinical situations. Obviously, there's situations in which virtual care isn't appropriate, but in the vast majority of situations it is. The second is, does the population actually have access to the right technology, access to broadband internet? Is the broadband internet affordable? There's kind of literal access. Is there broadband available to the person or to the population, and then is it affordable? And there are opportunities to link folks to programs that offer low cost or free devices and internet plans. There are federal programs and there are state programs, and I think organizations that do and practices that do a good job of providing virtual care to vulnerable populations are often linking to other resources and programs that exist in their community. And then finally, digital literacy. So does the population have the necessary abilities to use the digital technology? And in many cases, in larger practices or larger health systems, organizations are trying to improve digital literacy themselves. One example I think of is Ochsner Health System, based out of Louisiana. They have something called the OBAR, which is basically like a sort of help desk for digital technologies, and they have about a dozen of them spread across their service area, where people can go in and learn about using a remote monitoring device or using the Ochsner app in order to access virtual care. There are also city and state programs. Many public libraries have computer training or phone training programs. The Goodwill Foundation has a program on internet skills. And so I think there are a lot of resources that are available that can be linked to in order to ensure that vulnerable populations are able to access and have the same quality virtual care experience as other populations. I don't know what you'd add to that.
Yeah, agree with everything you just said, Jared. And I think this is also why we wanted to make this a foundational pillar for this blueprint for digitally enabled care that, again, expectation-wise for any vendor or company that's going into this space, thinking about access points from an equitable lens has to be just incredibly foundational. And if not, you're setting yourself up to be able to help to reach those that are more, I would say, how we refer to it at times is almost this Peloton crowd that, fortunately or not, have a lot of access points already, when those that need it most, again, we just have to be very deliberate about the way that new solutions, new technologies are built. And that takes a very multifaceted, I'd say, strategy at times. One thing I would bring up, two things really. One, the AMA leads an initiative called In Full Health, which is incredibly focused on how do we ensure that new technologies and innovations are being approached from an equity lens at the get-go. And again, kind of holding each other accountable to that too. And I think this goes hand in hand back to how do we amplify and share where that is being done correctly, right? And what are those kind of table stake expectations that health systems and practices and those that are the customers, be it, employers, and I think payers have a role to play here too, to make sure that that's set up right from the get-go. AMA, we also have a product called Physician Innovation Network, which is, you can think of as a more so Match.com to help connect physicians and health tech companies and patients and others in the industry as early stage as possible. And the goal here is to make sure that the products are being built with the right diverse, I'd say, set of user experiences from the get-go, right? And keeping that in mind really as the both product progresses, but even just to nail down what the problem statement is, because access oftentimes, and even digital literacy often at times, can be some of the biggest hurdles to overcome there.
Our next question, it's kind of a three-tier question, but looking at the role of virtual first primary care, how do you see optimal hybrid in-person / virtual care for people with complex health problems? And is virtual care an attractive option for people who currently aren't using a primary care physician?
I can start and Jared jump in. I mean, first and foremost, a lot of what we frame this around is wanting to ensure that continuity of care and that any existing physician and patient relationships, can stay as strengthened as possible. That said, from an access standpoint, of course, virtual can be a great, initial step into making sure you have access just in general, and then B, take the next step for whatever your kind of use case or scenario is, right? And I think that's where, from a digitally enabled care blueprint standpoint, we need to make sure that those kind of referral networks of sorts, or just those partnerships or collaborations, that's where this is so essential. Because if you go to a, let's just say, direct consumer retail experience to start, and you're not getting asked, well, would you like me to connect this to your primary care physician or provider? To me, that's a massive missed opportunity, and we're at risk of further fragmenting what already is an often very fragmented system. And again, need to think kind of with the end in mind of, from a patient and user experience, you want that to be as coordinated as possible, and you want to make sure that you've got a very kind of team-based care, and be that in-house of one institution, or be that the larger scope of, who is kind of helping you around or along your journey as a patient. All of those kind of puzzle pieces need to flow in together. And that's where I think collaborations and partnerships will be absolutely essential.
Yeah, I'll just add 2 points to what Meg said, which I agree with everything Meg said. The first is, so on the question of, is virtual care an attractive option for people who aren't using a primary care physician? I think we need to kind of face the reality that the latest data show 3 out of 4 Americans have a primary care physician. So that's pretty good, but that still leaves 80 million plus people who don't have a regular primary care physician. That's a huge segment of the population. It's a lot of people. And I think there are myriad reasons that that's the case, but for a certain segment of that population, it's because the current primary care offering doesn't work for them. It's not accessible. It doesn't match to their work life or home life. It's not as convenient as it could be for them, or it's not as affordable as it could be for them. And so I do think there's a role for virtual care and improving access to people who don't currently have a regular source of primary care. Agree with everything that Meg said about it being really highly connected to in-person care when the person needs in-person care, and to specialty care when inevitably specialty care is needed. The other thing I would say about virtual first primary care is, I think in a lot of cases, virtual first primary care is being linked to virtual first health plan designs. And I think there's also kind of a segment of the market for which those plan designs may make sense. One risk that I sort of see is that those plans don't lead to kind of continued adverse selection of the sort of Peloton population that Meg's talking about, and doesn't sort of exacerbate an existing kind of cherry picking, frankly, that exists. So I think in cases where it's used to improve access, that's great. I think where it's being used to really kind of steer people, and there isn't an option for in-person care where someone really needs it, or there's kind of benefit design that's steering people to in-person care, to virtual care, when they really should be given the kind of option without any financial implication for accessing in-person or virtual care. Those are just some of the things that I kind of am looking out for in some of these new designs.
And I'd layer in and just say, I think that's why it'll be so important, and what we're planning to do next in collaboration with Manat and these 40 plus, right, and we want you to join us, contributors, is work backwards from those top use cases to both start to see the outcomes data, right? And again, more comprehensive than just the financial outcomes data, but really clinical outcomes that are being seen across the board, and also an acknowledgement. And I think at times this can get a little gray, that when you hear virtual first, to just acknowledge that that's not virtual only, right? And that's the whole intent behind digitally enabled care, is finding ways to really optimize in person and virtual based on the use case, right? And based on the use case and also patient population and patient needs, and also autonomy for physicians and the care team to be able to make those decisions.
I'm going to pull a couple questions from the chat here in the Q&A. So for virtual care, even if the information is going to get back to your primary care provider, the time needed to ingest that information, synthesize new insights, is not reimbursed. So thinking, how would you both envision true integration?
I think a great starting point, and mention that kind of second piece of what we really want to build out, is how, based on different scenarios, people are going about getting paid for this today, right? And I think step one is kind of demystifying some of that, and again, raising awareness for what existing codes exist today, for both kind of combining kind of a tech stack of sorts, and then also in-person services and offerings that need to go into that scenario. So step one, what existing codes exist today, and then again, kind of a digging into or double clicking into who is paying for what, like already, right? And for the private payers, if they aren't currently covering something, how can we help nudge based on additional outcomes data that we can help to collect, and also kind of from an advocacy and policy standpoint to help to nudge that in the right direction. But I think we need those two worlds to kind of work hand in hand to be able to see an aggregate of outcome like showcases that we can bring to life, but then two, to be able to start to better spotlight the existing like payment scenarios that exist today. And then if and where there are truly gaps in payment and coverage and coding, that is where I mentioned earlier, AMA's Digital Medicine Payment Advisory Group really was created to help to both aggregate and identify evidence that needs to be collected to make the case for additional both codes, but then also kind of nudges in the right direction for reimbursement for the industry.
And would just add to that, I think it's important to be remiss not to mention that it's important to think about this integration happening in the context of a national shift towards more value-based payment models, right? Across all payers. And I think that physicians need to be paid for the work they're doing. I also think that there's been a recognition that we should be, rewarding value and quality as much as possible. And so in addition to making sure that when there are gaps in reimbursement codes, that new ones are created, and when there's gaps in payment, that payers are kind of covering the codes that are available to reflect the work that's being done. The incentives are also aligned from a financial perspective to do what's best for the patient. And that will, ultimately, hopefully there's some evidence emerging that as there's better coordination between primary care and specialty care, you're able to save money down the line from preventable ED or inpatient visits, and hopefully that creates the financial capacity to, again, reinvest in primary care, which I think Andrew did a really good job of, of outlining the importance of in the presentation during the panel discussion, excuse me.
Another question from the chat. How do you think about low-value healthcare, and how can digital solutions create real insights and decision support to drive next best actions for providers?
Jared, do you want to kick off with that one?
Sure. Yeah, I think it's a good question. Certainly, as we think about the healthcare kind of delivery model of the future, we want to be providing as high value care as possible. hard to argue with that. I think how do you actually identify, what services are high value, what services are low value, and how do you make that information kind of available as rapidly as possible, kind of at the point of care to the physician. I think there's been, a lot of attention historically kind of given to this at a kind of policy level, I would say. But I think the reality is for most physicians in practice today, that level of kind of clinical decision support doesn't really exist for the vast majority of physicians. I think it's a big opportunity.
Yeah, I would just layer in, and we've mentioned a few times that framework, our return on health value framework here, and I think this is again back to the use case and what success looks like to you within your practice setting or within your practice or institution, and having to kind of recognize what you want to measure and then prioritize that, right, based on your own environmental variables for your setting, but then two, to consistently start to look at what outcomes are we seeing, right? And we saw and mentioned this in the panel discussion that in a perfect world, you'd start to work towards kind of a formulary of sorts of what is working and what isn't as much, right? And what are we potentially kind of wasting time on from like a low value perspective when we've got so many kind of things to check off the to-do list. So I think we're getting there. I think a starting point though is kind of recognizing where there's the best fit and recognizing what your goals are, and then starting to actually generate outcomes data around that.
We have time for one more question, so I'll pull this one from the chat. This person said they agree with what Dr. Berry said. Healthcare is not the same as banking. The stakes are higher. We need to have higher standards of care. And aggregating, the standards need to be high, and aggregating not just healthcare, but barriers to health, social determinants of health, behavioral change is critical. Who should pay for this, do you think?
Yeah, to me, I mean, this is again where no one group, right, is going to do this alone. And I think it's both expectation setting and, of course, I would say when you say who needs to pay for what, kind of first level setting on the who is paying for what today, right? And that's what we plan to additionally build out here in 2023. I think if you were to look at kind of the current state, obviously employers are footing a lot of the bill right now, and often too are even, utilizing a lot of these digital health solutions and tools. Then on the flip side, from the health system perspective, attempting to assess and navigate what is, truly reimbursable, and then what's CMS covering versus what are private payers covering. To us, we need to just further decipher that and again, bring that to life in terms of what's possible. And then this goes hand in hand with starting to amplify where we're truly starting to see some successes and just partnerships come to fruition as a result.
Yeah, I mean, I'd also just complement that by saying that, well, we're paying for all of it, is sort of the first thing ultimately, either through in Medicare, through our payroll taxes, and in Medicaid, sort of through state budget and federal match, and as employees of companies where often we're kind of contributing to, premiums and copays and deductibles. And so I think it's really a sort of societal issue. To Meg's point, this is not, we could play kind of whack-a-mole all day on sort of who should pay for this stuff, but we all need to kind of be paying for addressing the social drivers of health in particular, and for behavior change and some of the other ideas that were mentioned in the question. I think we are starting to see a real recognition that, if we don't pay for these types of investments, we're going to continue to see healthcare costs just go up and up and up, and life expectancy sort of stay the same or continue to decline as it's done for the past few years. And so I think we're seeing in Medicaid recently, the administration has indicated that there's going to be expanded ability to pay for investments in addressing the social drivers of health, like transportation and housing and other investments. And so I'm excited about that. I think the same has been true for a long time in Medicare Advantage, and we're continuing to see sort of expansion of services there. And I wouldn't be surprised if we see employers next sort of thinking about other opportunities for investment beyond what they've typically been paying for to really try and deliver high quality care at lower cost, which is sort of what we're striving for.
Mm-hmm.
Thank you both so much. To close, I will share here, if you want to read the Future of Health report, this is the QR code. Additionally, as Meg mentioned, please reach out to us if you want to discuss this further. If you want to share case studies, you can reach out to myself, laura.fritchie@ama-assn.org, or Stacy Lloyd. And also, if you go to our Future of Health Immersion Program website, we do have a link for you to reach out to our email as well. Thank you, everybody, and have a great day.